Hi, I'm Wolfgang Hiddemann from Germany, and I'm co-chairman of the International Workshop on Acute Myeloid Leukemias, which took place here for the first time. And I think this workshop was actually needed because we have so many new data in the treatment of AML. And we just had a very interesting session on how to improve standard therapy for acute myeloid leukemia. And in that session, I was accompanied by Laura Cicconi from Italy, the other co-chairman, Alan Burnett from the United Kingdom, and Klaus Metzeler from Germany. I would like to discuss with you briefly what we could show on new data within that session. And maybe if we start with the last talk first, Laura, if you could tell us a little bit about the improvements that you see in the treatment of acute promyelocytic leukemias.
Yeah, acute promyelocytic leukemia is a paradigm for success of targeted therapies, in particular all trans-retinoic acid and arsenic trioxide, and now cure rates exceed 95% in APL patients. In particular, in the last year, the combination of these two drugs and also the minimizing of conventional chemotherapies in the setting of patients has allowed very high cure rates with also mild toxicity profiles. And I also presented today the updated data from the GMEMA APL 406 trial, and also in the very long term, 72 months of median follow-up, the event-free survival is incredibly in favor of the ATRA combination as compared to the standard AIDA. However, despite this success, there are a lot of open issues also in this disease, in particular the early mortality rates, which are still very high, up to 30%, also in very well-experienced centers and also in very well-developed countries, but also some other issues like the optimal management of patients with high-risk disease, and also the recurrence of the disease after arsenic, so how to treat patients who now receive arsenic trioxide in front line. So I also reported some of the results that we obtained in our lab in dissecting a little bit more the mechanisms of resistance to arsenic trioxide, so additional mutations, and also in particular mutations in the binding side of arsenic trioxide within the PML gene, which is involved in the PML RARA translocations. So a lot of work to do also in this disease, but I think this is a success in the hematology field, so we're happy of that.
Yeah, absolutely. I mean, when you look at the results of APL, I mean, it's really a success story. And when we look at the other end, let's say, of the leukemia treatment, we come to patients with poor risk, AML particularly. And Klaus, if you could explain a little bit how those patients are defined and what you could show us this afternoon.
Yes, indeed. I focused on the other end of the spectrum of our AML patients in my presentation. And if we think about adverse risk AML, the definition of that has evolved over the last couple of years, because now we don't only include cytogenetic chromosomal aberrations, but also for the first time molecular mutations in certain genes as markers of high-risk AML. And that has led to a dramatic increase in the frequency of patients that we do classify as high risk. So with these new markers, overall about 40% of all our AML patients are adverse risk. And if you look at older patients over the age of 60, it's more than half of them. So this is a significant percentage of our population. And with the available standard therapy, so that means cytarabine, anthracycline-based induction, consolidation therapy, and allogeneic transplantation when it's feasible, these patients indeed have very unfavorable outcomes. In the older patients, that's not surprising. They have a 5-year overall survival of less than 10%. But even if we look at younger patients below 60, if they have these adverse risk features, their 5-year survival still is below 20%, so far from being satisfactory. And we also could look at patients who did receive an allogeneic transplant, which often in our mind is the solution to high-risk AML. But we see that while this does lead in improved survival, still the outcomes are far from what we would hope to see. Within this high-risk subgroup, we can delineate either by using molecular features, TP53 mutations, or by using novel markers, gene expression signatures, subgroups of very high-risk patients who have even worse outcomes, who have essentially no long-term survival with the therapy that we're currently using. And we think that, that this is actually the population that we should focus on in our clinical trials, because this is really where the unmet need is. So while in my presentation I was focusing on what we achieved with therapies in the past, you in your presentation gave us an overview of where there's still room to improve these therapies, and also a view into the future, what we can do to really move ahead and make progress.
Yeah, that's true. I mean, this was the topic that I dealt with, namely the challenge to improve post-remission therapy. I mean, with nowadays standard induction treatment, we get approximately 70% of patients into remission, but only a relative minority of patients are actually really cured. And so the question is, how can we improve that situation? I mean, there have been numerous attempts to intensify first-line treatment, but also to intensify consolidation treatment. And just recently, a couple of new studies were published, one applying clofarabine in combination with RSC, another one applying increased doses of idarubicin, and both showed a kind of small improvement in the progression-free survival. In addition, also a kind of revival of the discussion about the value of autologous transplantation has started. But I think we must say that by conventional means or improvements of conventional therapy, which is also not specified for specific subgroups, there might be some improvement, but the improvement is probably relatively little. Well, one of the big problems that we have in post-remission therapy is that it's a kind of black box. We don't know actually what is going on in remission. And one approach to try to solve that problem and to get better insights in what the leukemia is actually doing during remission, we have the possibility to monitor minimal residual disease either by molecular means or by just most recently flow cytometry. And there were convincing studies from David Grimwade's group a couple of years ago showing that monitoring of minimal residual disease by molecular means has a high relevance for the outcome of patients. And similar findings have now been reported also by flow cytometry. So I think we have now the means to identify patients who have residual disease after successful induction therapy. But the question is, what do we do with those patients? And can we actually really improve on patients who are MRD positive in remission? And the kind of disappointing part is that these studies that have been done so far show more or less convincingly that if you apply allogeneic transplantations to patients in remission but with MRD positivity, the outcome remains poor. The only exception, at least that I know, was a recent study from Italy where the group from Adriano Venditti could show that they can actually overcome the poor impact of MRD positivity. But the bottom line is really that we really don't know at the present time how to best deal with MRD positivity, and we really don't know whether MRD monitoring will help us to select the most appropriate post-remission therapy. So I think what we really have to do is to try to better understand what is biologically also going on in remission. And there are data from our own group in Munich, from Klaus Metzeler, who showed that, for example, there could be pre-leukemic clones which remain present in remission, and that the presence of those persisting clones has a prognostic implications. The most interesting finding, in addition, is that when you apply allogeneic transplantation to those patients, this poor this poor prognosis of patients can possibly be overcome. And another group from our department around Philipp Greif has done exome sequencing in a series of patients at diagnosis, in remission, and at relapse. And he could show, let's say, a clonal evolution, and he could show that particularly epigenetic regulators have a gain of mutations in remission or between remission and relapse. And that's insofar important since some of these epigenetic regulators can change the sensitivity to certain drugs. So in conclusion, I think our current strategies for post-remission therapy are somewhat, well, not really satisfactory. But I think we have now tools for a more intelligent and biologically driven selection of post-remission strategies. Well, I think that's one of the challenging things that we discussed during that session. But I must say that those approaches usually are applied only to patients below the age of 60.